Surgical anatomy of temporomandibular joint, and we will have a complete array of discussion regarding the anatomy and the relevance of anatomy for the further studies that have been we are going to have a discussion on today. So what is temporomandibular joint? Well aware by most of you, all the amateurs who are entering into maxillofacial surgeries and the stalwarts. We all know that it is the joint, it's composed of the temporal bone of the skull and the mandible. And the two bones are held together by a specialized dense fibrous structure, the articular disc, several ligaments and numerous associated muscles. It's a beautiful article by Keith in the Journal of Oral Surgery of 1984. I think this is one of the landmark articles which I think each one of you have to refer for understanding the anatomy and the relevance in surgical incisions. So prenatal development starts about 9 weeks with the Meckel cartilage developing and then ossification at 12 years. So during the postnatal development, there is a difference in the condylar from 9.6 mm at birth to 15 mm in permanent dentition. Anterior-posteriorly, it's about 6.5 mm from eruption to completion of deciduous teeth, and 7.3 mm under adult size. So glenoid fossa also 3 times it becomes more deeper in the adult than infant, and cartilage slowly replaced by fibrous tissue with age. Although the articular eminence is rudimentary at birth, growth increases after eruption of the permanent incisors. So various age changes in mandible, and of course we know that it's a diarthroidal joint, also called as gingival-arthroidal joint, and it has a content of it being called as a synovial joint because the synovial fluid is there as a lubricant in the joint. So some of the important articulating surfaces are the temporal bone, the mandibular condyle, superior and inferior surfaces of the articular disc. So the word gingivimus is a Greek word. Of course, it has evolved from the Greek word gingidomos, which means a hinge, and the word arthroidal comes from the Greek word arthros, which means to fit. So it's a bicondylar, gingival, arthroidal, compound, complex, secondary synovial joint. So the bony structures, as we've already said, that the largest is the articular or the mandibular fossa, which is a concave structure, and the second portion is the articular eminence, which is a transverse body bony prominence, which is usually thick, and the third portion, of course, is the surface of the temporal bone. And the mandible, as we all know, has the condyle, which is about 15 to 20 mm in width and 8 to 10 mm in anterior-posterior dimension. So the head itself looks like a rugby ball. It's the medial pole is greater than the lateral pole. Posterior surface is greater than the anterior, and it has a 140-degree angulation with the EAM on both the sides. So the eminence itself has 3 layers, which is the fibrocartilaginous layer, and an undifferentiated connective tissue, and a fibrous connective tissue, which acts like a saddle. So this is how it appears in the cross-section. So the changes with age, again, the edentulous jaw, there is more resorption that is seen along the from the fossa to the eminence. As a result, the convex posterior part of the eminence becomes flatter. The glenoid fossa is shallow and it's an oval depression in the infratemporal area. So we see the relation of this to the temporal bone. So in toto, we are discussing about the bony components, the soft tissue components and the muscles. All of this are heading towards the topic of internal derangement as well as temporomandibular joint reconstruction. So some of the important structure in this area is the chordotympanic nerve, which appears to be medial end of the petrotympanic fissure, almost close to the spine of the sphenoid. So this is the location of the chordotympanic nerve, and the roof of the fossa is very thin. That's why we have to be very careful when we are attempting to do any temporomandibular joint surgeries with the fear of CSF leak. So the cartilage and the synovium of interest to all of us in the present decade, we need to know that each of this synovial cavity has the synovial fluid, which has proteoglycans, glycosaminoglycans in it, and of course the composition itself gives a cushion, and it functions to act like secrete hyaluronic acid, which is the component of the synovial fluid, and it is a richly innervated vascular structure without an epithelium. So, as I already mentioned, the content, So we go to the capsule, which is a non-elastic membrane which is surrounding the TMJ and seals the joint space, and stability in proprioception in the capsule. The articular disc, again housed by the various areas of its movement, is very flexible, is attached to the capsular ligament, and some of the fibers of the superior head of the lateral pterygoid insert on the disc at its medial aspect to stabilize the disc in the mandibular condyle. So it has, the meniscus itself divides into the lower as well as the upper compartment. As you can see in the diagram, the two compartments are divided by the articular disc, and the lower one is also called as the condylodiscal complex between the condyle and the disc, and the upper one or the superior compartment is between the disc and the temporal pole. So the retrodiscal tissue has, again, it can be divided into various regions, the anterior, intermediate and the posterior. Anterior is nothing but the joint capsule which has the spino-meniscus fibers, and posteriorly the disc is attached to the retrodiscal tissue. So it forms the superior retrodiscal lamina. So the inferior aspect again is called as the inferior retrodiscal lamina. So this is how the attachments of the capsule and the lateral ligament of the temporomandibular joint per se is. And so all of this helps in the functioning, allows for both rotatory and translatory motion of the joint. So you have the ligaments again, which are of importance to us, especially when we are doing the various surgeries and its rehabilitation. So all the ligaments, to revise, the discal ligaments, the capsular ligament, the temporomandibular ligament, and the accessory ligament is sphenomandibular, stylomandibular, and also we have another one which I will discuss at the end of this ligament part. So basically this discal ligament, it restricts the movement of the disc, and it acts as a hinge movement between the condyle and the disc moves passively with the condyle. In the lateral ligament, it is again a fan shaped, it has got an outer oblique portion which is to the outer surface of the condylar neck, and it's got a horizontal part which attaches to the lateral pole of the condyle and the lateral margin of the disc. It prevents the same side and the contralateral dislocation. This is relevant in the cases of temporomandibular joint disorders. Accessory ligaments again attached to the spine of the sphenoid, then styloid process, we have the stylomandibular ligament, and retanicular ligament, which is the supply towards the capsule, towards the posterior lateral part of the retrodiscal pad. This is another accessory ligament which is seen. So each of this is important for us because we need to understand the various vascular supply, nerve and the arteries which are attached in and around the TMJ capsule. The pre-auricular exposure of the TMJ area almost invariably injures this nerve, and that is the facial nerve. The damage is minimized by incision and dissection. The temporal extension of the skin incision is done so that it can be located posteriorly, so that the main distribution of the nerve is not dissected and it's retracted towards the flap. So the vascular supply itself is by the superficial temporal and the maxillary arteries posteriorly, that is medially also, and the mesenteric artery anteriorly. There is a rich plexus of veins in the posterior aspect of the joint, and it's associated with the retrodiscal tissues. So the marginal mandibular nerve is of relevance to us. We've been speaking about this from yesterday. I would just touch upon it, and relevance comes in this article of Dingman and Graf, which he describes about the surgical anatomy, where he found about the branch being about 1 centimeter below the inferior border of 19% of cases. But then in the important finding is 20% of the cases had a single marginal mandibular branch, and 67 had 2 branches, and 9% had 3 branches. Again, when we have to approach for TMJ prosthesis surgery, we need to keep all of this in consideration. The surgical anatomy of the cervical distribution by Atkinson also describes that 53% of this was below the inferior border and 6% farther with the distance. So all the publications now are related to 1 centimeter distance in front or below the angle of mandible, and hence the modifications of the various incisions. So the muscles which are involved, the temporalis, masseter and medial pterygoid. Jaw opening muscles are lateral pterygoid, suprahyoid and infrahyoid muscles. Temporalis again is attached at the anterior border of the coronoid process. Along all of this assist in the jaw movements, with the masseter also being, this concentration of masseter is in terms of the incision of the retromandibular as well as the submandibular incision, transparotid, all of these will come into consideration with the muscle group. Medial pterygoid not much, helps in terms of the movements of the joint. So suprahyoid muscles also help in jaw opening and swallowing. So regarding the inferior joint cavity, they have a rotational and a hinge movement, and the superior joint cavity has a translatory and a sliding movement. So this is what we see as a normal function of the temporomandibular joint. And two things that we consider, and we will be having a discussion on this, that is the disc displacement without reduction and disc displacement with reduction. So again, whether clicking is there upon function or not, with repeated episodes of limited mouth opening, whether it's intermittent locking or it's a non-painful condition, what are the various combinations, this will be dealt in detail, just giving an overview. And Wilkie's classification is something which we look forward in terms of its assessment. So all the relations, superficial and superior relations, we've already discussed. Auriculotemporal nerve also is to be considered during these surgeries, and the inferior relations in terms of the parotid gland, anterior relations in terms of the lateral pterygoid and the deep temporal nerves. So all of this is important in terms of the relation of the temporomandibular joint. So the main thing, this is a very important slide, this talks about the middle meningeal artery in Nonjan et al.'s article in O, about the medial lateral distance about 31 mm and 2.4 mm anterior-posteriorly. Carotid artery is about 37 mm mediolaterally, and again internal jugular 38.3 and mandibular nerve about 18.7. Very important distances that you need to keep in mind. So regarding the, so again, when we are looking at the posterior neck of mandible, it's the superficial temporal artery, auriculotemporal nerve. In terms of the incision, it would be the transverse facial artery also, and maxillary artery, which is beneath the condylar neck. It can be endangered in the cases of where we have to do a condylotomy and resection of the bony ankylosis. Again, as we've already discussed yesterday also, I would again stress on this, the facial nerve location, the distance that is there as described earlier, we need to keep this in consideration. Facial artery, again, we've already discussed about this. Coming to the facial vein, again we have a parallel facial vein which is running along the course parallel to the facial artery, but then it will always be considered in the submandibular incisions and the retromandibular incisions as we've already discussed. So all of this, the temporal branch crosses the zygomatic arch at varying location, and it's a range of about 8 to 35 mm anterior to the external auditory canal, and therefore the protection of these temporal branches is of a prime consideration. This is described in the article by Millero et al., which describes about 1.68 to 0.49 centimeters. So again, parotid gland is one more important structure, especially the parotidomesenteric fascia. This particular fascia needs to be taken into consideration during the incision, especially of pre-auricular incision and a combination of two incisions to get access to the temporomandibular joint. So these are all the various incisions. I will not go into it because that comes from the forte of Dr. Sonal. We just need to consider that whenever we are considering the pre-auricular incision, the vessels need to be taken care of. The flap needs to have an area where the injury to the superficial vessels are not damaged and is retracted anteriorly in the flap. So each of this has to be taken care as we've already discussed, and the kaleidoscope is anything between the pre-auricular incision, submandibular, periangular, and the various combinations for the axis. So all of this I just want to brush through, and we have the alveolar papillary incision. I think she will be covering in her thing. So some of the two articles which I would like to mention, which I think is the talk of the day, one study, the Indian study by Dr. Abhay Kamath and group of the modified periangular approaches that was of course used for the condylar fractures and the incision. This will be the discussion for today, and I think we will look forward for other advances also. We have the endoscopic approaches and vacuuming approach which was described by Garcia in 2015. So again, endoscopic will be covered in the next session. So surgical incision are a primary purpose of understanding the anatomical landmarks, make sure that the function and the cosmetics is taken care. Thank you, team Janssen.